Thank you, Bob and Marge, so much. I would say primitive, but it was a lot of fun. And I think both of us enjoy those sort of prototype type things. Marge is considered a prototype fellowship. But, I'm forever grateful. I'm going to talk about some of my own complications, and it's hard to do that because you sort of expose yourself, but you learn something in the process and sort of how we resolved it. These are my disclosures, and this is just something I said to myself during all this. Before you can learn to correct the mistakes of others, you really need to fix it yourself and learn how to fix it yourself, which means making a lot of calls to colleagues and a lot of emails and learning. A lot of complications that come into our office fall into one of these categories, including, and the one that doesn't really come in but are developed in the practice are iatrogenic, and I'll show you some of those today. But when you're dealing with, if you're practicing good medicine, you're going to see these come into your office, a lot of what you've seen today already. It's daunting talking about IPL in front of Mitch and Bob, but I'll talk about it. This patient was first ruled out for reflux and came in sort of with this presentation of essential telangiectasias in the legs. A difficult thing to treat. She was very concerned about it. Didn't wear long pants. Decided to do some test spots and try some sclerotherapy. And you can see the results there. And I think doing a test spot is always a good thing, as long as you follow it up with the proper treatment. That is, the sclerotherapy with different agents. This was glycerin shown here. Didn't do much. Just too much hydrostatic pressure, I think. But she was clear on reflux exam. So here you can see that she did pretty well, and I was feeling good about proceeding with this treatment. Of course, the time of year matters, and I didn't pick up on that. So we looked at her in the spring, and then we did her treatment later in the fall, and actually used the same energies. I figured, why not, right? But of course, and she didn't look tan, but she had been out, of course, and just didn't recognize that. So she comes in 1 week later looking like this, and very sort of upset, or she called and we brought her in. And I knew then it was it was too much energy. And the thing about these delayed reactions in IPL is they're definitely delayed. It might take 5-10 minutes for you to realize you made a mistake in some patients. You just have to be patient and watch it. And then you have to follow through with it. So this was, some of the desquamation, and then, she finally worked through this and looked at the hypopigmentation. And so how do you manage these patients? Well, I want to get them over the stinging, itching, and all that. So I used topical oral steroids. I thought Uniboots would be a good idea with occlusion of clobetasol, just because she couldn't get to it and she couldn't see it. One of the tricks is really getting it out of sight, so it's out of their mind. And so she would come in and we would replace these Uniboots every week. When she started repigmenting, or trying to repigment, I added tacrolimus, time, photoprotection, a lot of care and encouragement, and yet spent a lot of phone time and visits with these patients. And then when she was hypopigmented, I went back to a little bit of controlled sun exposure, some UV exposure, care and encouragement again. This wasn't her, but sometimes you have to go back and fix the striping and so forth that you may have. On extremities, it can be sometimes hard to line things up, depending on your pulse light device. And so this was her at 4 months out, doing a lot better, and ultimately she evened out even more. And so just taught me these things, and I should have known this from fellowship, and I should have known this, but you get caught up in the moment. Take things stepwise, and then adjust for what you see before you go forward with the treatments. So luckily, she's doing well. In fact, she called back, this has been years ago, she called back just last week wanting to come in for more treatment because these started to redevelop. So we'll see, I don't know. Case 2, resurfacing gone awry. This was from years ago, and again, with this panel, it's sort of hard to show this, but these are mistakes that you make. This is sort of the perfect storm. It was sort of a challenging case, but not really. But what made it challenging was it was a colleague's wife. I was eager to try something different. And the treatment was performed, as it turned out, right before COVID hit, as you saw with another presenter. So that was frustrating for me. The patient lived 90 minutes away. She was older. They were deathly afraid of driving into the city. In fact, they were from the hometown that I was born in originally. They did not want to come in under any circumstances. In fact, they went even further in isolation into the mountains. So doing things was very tough. In fact, getting cultures of the skin was very tough. The husband was a dermatologist, so he sort of related to me, but he was a lot older and had never done any device work. So this is the colleague's wife. It's not too bad. It's orally, perioral rhytids, periocular rhytids, and foot anastosis. So it wasn't, on the scale of things, wasn't too challenging. So this was the time course from her phone, from her iPhone. So that was just, I think, a week out or 4 days out. And then, another week out after that, so I'm in trouble here. In addition to some of the poor technique that you can start to see, I just was way too much on the energy. And then you can see the time course 2 days later after the weeks, and then another 2 weeks. And this is all trying to initiate therapy remotely. They would not come in. Cultures were all negative, unfortunately, because we didn't have anything to, I felt like I didn't have anything to blame it on except myself, but luckily we didn't have to do any the antibiotic therapy necessarily, although she was on everything, antibiotics, antiretrovirals, antifungals before she started. And then she started to turn things around, I thought. I do a lot of occlusive thin duoderm dressing. It's been a godsend for me in terms of healing wounds that take a little bit longer to heal, the extra thin kind. But then you can start to see this developing after the fact again, and she wouldn't come in. I was just looking at these pictures, and just what was said by Henry starting, if I could have wheeled the PDL to her in the mountains and plugged it into the appropriate outlet, I would have done it. I couldn't do anything except watch and watch and watch these develop and just try to encourage her. So the course went like this. I ordered all this stuff on Amazon, had it sent to her. I didn't want her getting the wrong stuff. We did some oral steroids, interlesional 5-fluorouracil. When she was finally able to come back in, we tried some regenerative things, PRP. I tried to stabilize the area and reduce tension with botulinum toxin, which I think helped in the mentalis and orbicularis oris. Of course, PDL was a mainstay in doing that, but sometimes these vessels are, you just max out, so you have to play it with every visit. I ended up switching to different IPLs, and I found that the Nordlis with a very, very short pulse width actually gave me the best results with vascular. Of course, that sequence of non-ablative and ablative that Henry explained and knowing when to do them, and then weekly phone calls with their spouse, because I knew at about the 3rd month I was going to get a call, and it wasn't from her spouse. It was going to be from a colleague of theirs that wanted to know what was going on, and it happened. And luckily, it was another dermatologist in the state, and I talked to him, and we held hands for a month, monthly visits for an entire year. In fact, at the last visit, she was saying, "Is that all?" I was like, "Yeah, that's all. I think you're good." So she started to get better and better with these treatments. Again, you can see technique was not the best, and eventually resolved after this was her 1 year visit. And so I learned a lot from this patient, and I still see her on occasion. I think they've moved to the mountains now permanently, but this story, it just teaches you a lot about how you can manage patients. And thank you for your attention, Bob, and thank you for the invitation.